Okay. So is everyone able to see the my video as well as the slides right now? Good. Okay, perfect. All right, so let me start by introducing myself. My name's Stephen Tucker. I'm one of the comprehensive ophthalmologists here at the Virginia Eye Institute. I specialize in cataract and refractive surgery, so I do LASIK, PRK, and a lot of cataract surgery. That's really what I specialize in. I've been in the Virginia Eye Institute for about 4 years. Before that, I was at Emory University in Atlanta, Georgia, and that's where I did all my formal eye training and surgical training. And before that, I was in Pennsylvania at Penn State for medical school. So that's a little overview. I figured I'd tell you just a little bit about me so you kind of have an idea of who's talking to you. Outside of work, I'm married. I have 2 kids, a 4-year-old and a 2-year-old. I couldn't do a presentation without at least showing one picture of my family. So my kids, Annabelle and Dawson there on the left, my dog Lizzie, and then that was just us last weekend, strawberry picking. So we do a lot of outdoors, running, biking, hiking, play the piano, gardening, all those different things. So just to give you some idea of who I am outside of work, everything else will be focused on cataract surgery and ophthalmology here. But all right, so let's start with the basics. We're going to go through what a cataract is, some of the basic terminology we use, some of the signs and symptoms, and then we'll get into the surgery itself. So first, we're going to talk about some different definitions. So a cataract is a clouding of the natural lens of the eye. It focuses the light on the retina, which is kind of like the camera film. And so it's a focusing tool, just like a lens in a camera. As you age, it can get cloudy. Basically, proteins accumulate, they cross-link, and they turn it from being a clear structure to kind of a yellow, cloudy structure. All right. We will be talking about astigmatism as well today. Astigmatism is a focusing error. When we talk about it, it causes blurred vision. And I like to talk about it with the analogy of a baseball versus a football or a basketball. So a normal patient with no astigmatism, the front cornea will be shaped just like a basketball or baseball, perfectly round. If you have astigmatism, it's like a football where when the light comes through, it focuses in 2 different planes. And you need to correct that with a lens if you don't want to have blurred vision. The picture at the bottom shows what astigmatism can look like. Basically, it can cause glare and just decrease vision. Intraocular lens, a common question is, what's going in my eye? So after we take the cloudy lens out during surgery, which we'll get into, we put a new lens inside the eye. It's usually an acrylic or a plastic material, and it sits right behind the colored part of the eye. And it replaces where the previous lens was. So you have to get a lens put in. If we don't put a lens in, you won't be able to see well at all. And so that's kind of not optional. You can take the cloudy lens out, you put a clear lens in. Okay. So glare, halos, and starbursts. These are some symptoms and side effects that we'll talk about today. I wanted to show this slide. All the way to the left in your image shows just a light. So whether it's a headlight or street light, and then the 3 pictures to the side show what some of these symptoms are. So glare, there's just kind of light emanating from it. Halos, self-explanatory. You've got circles going around the light source. And starbursts, kind of like a star where you kind of see the streaks coming out. And we'll talk about that as a symptom as well as a potential side effect when we go through the lens options. Symptoms of cataract. So how do you know if you have a cataract? So myopic shift, which means that your glasses prescription can change. So as that lens thickens, it can change the glasses prescription, and that can be a sign of cataract. Glare, which we just talked about. Glare, halos, starburst. So when you look at a light source, if you're having some of those issues. Faded colors. Faded colors is very common. A lot of patients do not know that their colors are faded until they have the surgery, and they come in and they say, wow, colors are so much brighter than I can ever remember. And so, faded colors, a lot of patients just notice afterwards that it's better. Difficulty in dim light settings. Night driving is probably the #1 reason people come in for cataracts, whether it be the glare and halos from light sources, just difficulty seeing in dark settings, etc. That can all be from cataract. Light sensitivity, again, the sun can scatter, the cataract can scatter that light, and that's what causes the symptoms. And then just blurred or decreased vision. If we can't get your vision as well as you want it to be with glasses, then, it's oftentimes a cataract. Of course, you need a complete eye exam to rule out any other causes of the decreased vision, whether it be glaucoma, macular degeneration, dry eye, and we'll talk about some of those as we go through the presentation. So decreased vision has a lot of impacts. We know how important good vision is. This slide is just to go over that even with one line decrease in vision, there is an increase in falls and fractures. You drop a couple more lines to 2040, just general decrease in global health, activities of daily living. And one more line after that, there's even a greater risk of death and vehicle accidents, etc. This is just to show that, good vision is important. Cataract statistics, I'll go through this slide quickly, but basically a lot of people have cataracts. If you live long enough, you essentially develop the proteins that accumulate in the lens, and you develop some clouding of that lens. There's approximately 4 million surgeries done every single year. And as part of that, 50% of those patients have clinically significant astigmatism, or more than 0.75 diopters, and we'll talk about that. And then everybody over age 40 basically develops presbyopia. Presbyopia is a need for help with reading vision as you age because the lens is less flexible. So many patients have all these conditions, and we'll talk about these as we go. Okay, this is a common question. How do I know if I need surgery, or when do we decide to do surgery? So, the way I describe this to patients is, does your vision, or do the visual symptoms bother you enough that you want to have surgery? Do you have a functional complaint? So coming in and saying, listen, I really don't want to wear glasses anymore, that's great, but that's not the main reason we do surgery. So unless you have a functional complaint, your insurance won't cover surgery. So what are functional complaints? Having trouble driving at night. So, those oncoming headlights, the glare, and the halos make it very difficult to drive at night. I have trouble seeing the signs in the distance, even with my glasses on. The glare from the sun makes it difficult to drive during the day. It makes me feel uncomfortable. I have trouble reading up close, even with my glasses on. And, a new glasses prescription doesn't fix that. And then just general decrease in vision. Like we talked about those numbers before, if your vision was 20/20 and it's dropped to 20/40 and the rest of the eye is healthy, and you can tell you're not being able to do what you need to do, then we do cataract surgery. Anisometropia. So if there's a big difference between the eye prescriptions, sometimes that can cause headaches or not be tolerated well, and that's another reason to do it. So when you have cataracts and they're mild, we can update the glasses, and that can fix a lot of the issues. That'll help with some of the glare and light sensitivity. Some folks will use kind of the yellow light filtering night glasses. That can help with some of the symptoms, but it reaches a point where really the only way to correct these symptoms is with surgery. And, we do that in collaboration. So you have the symptoms, we talk about them, we talk about whether the symptoms are from the cataract, and if so, then we talk about cataract surgery. So obviously you need to have the discussion with your ophthalmologist or surgeon to make this decision together, because it's really a joint decision. I almost never tell someone they have to have cataract surgery. I say, you will guide me in terms of when it bothers you enough that you want to get it taken care of. Once we decide that you're ready for surgery, we'll talk about what your goals are. And we're not going to go through this in detail, but this specific handout, but this is one that we use where we basically have you go through it and you talk about, what your goals are, what your hobbies are, how you feel about glasses. Are you fine wearing glasses all the time? Do you not want to wear glasses? Are you okay with them for reading or distance? And so this kind of goes through. It also asks about night vision and your personality, because all of those go into the decision and what type of lens would be best for you. So let's go a quick overview for cataract surgery. So this is what I talk about when someone comes into the office. I say, cataract is a clouding of the natural lens of the eye. Cataract surgery is when we take the cloudy lens out and put a clear one in. I like to use the analogy of a peanut M&M. We take out the peanut, that's the hard central part. We peel out the chocolate, which is the second zone, the cortex, and we leave that candy shell in place. And that candy shell is where we put the new lens inside. and that candy shell kind of holds the lens in place after the surgery. And so that's one way of looking at it. For surgery itself, we usually do them 1 to 2 weeks apart. You can go anywhere from 1 week, indefinite can be, you can spread them out as long as you like. But I typically do them about a week apart. We will talk about postoperative expectations. That is very important to talk about ahead of time so that everyone's on the same page in terms of what you're going to get. So whether you're going to have good distance vision or near vision or what to do there. All of these are related to, so the standard lens, which is what's covered by insurance, we'll talk about that in a few minutes. That'll give you good vision. You may need glasses. If someone comes in and says, listen, I'm perfectly fine with wearing glasses all the time, the standard monofocal lens is great. It does a great job of fixing the symptoms of the glare, the halos, the light sensitivity, etc. You just might need some glasses with it. And so it is important to know that when we talk about all these lens options today, we're really talking about how often you wear glasses, etc. Okay. There is no perfect lens option that makes your eyes like they were when you're 25 years old and you could see distance and up close perfectly with 0 side effects. We're not there yet where we don't have a perfect lens substitute. We've got a lot of good options, and that's what we're going to go through today. All right, so new slate. This is a common question that I hear a lot. Your current vision is going to change. So if you're nearsighted means you can see up close. If you're nearsighted right now and you can read up close, but you struggle in the distance, that doesn't matter. We're going to change what you are in the future. And so, if I say I'm going to correct you for distance vision, that doesn't mean you get to keep your near vision. And so we'll kind of go through the examples of that. Same thing with farsightedness. There is a lot of history that I like to know and understand, and I'll ask a lot of questions during an evaluation, or your cataract surgeon will ask a lot of questions, whether you've done monovision before, which is where you do one eye for distance, one eye for reading, whether you've had any refractive surgery like LASIK, PRK, or RK, and we'll go into more detail on that later, history of trauma, contact lens use, etc. Okay. It is important to understand you can always wear glasses or contacts after surgery. So if it's not you can never wear glasses again, or etc. So it's always an option to do that. I also want to make a point here that every cataract surgeon does things a little bit different. I'm trying to give a broad overview here. I will speak to some of the specifics that I do and the way I look at things, but just know every doctor you see, even though we're all part of the same group, will have some preferences in how they do things. So it's important to understand. Okay, so let's talk about risks. Overall, cataract surgery is very common. It's very safe. It's what I specialize in. I do a lot of cataract surgery. That being said, I tell every patient it is still surgery. Surgery has risks. Those risks include infection, need for second surgery, and then some of these I listed just so you have an idea of what some of the percentages are. Infection, very rare. Knock on wood, I've never actually experienced an infection after cataract surgery. Posterior capsular rupture. In my analogy, the peanut M&M, that candy shell that stays in place, it's only 5 micrometers thick, so less than 1/100 of an inch. There is a small risk that during surgery that opens up and either some lens material falls or some of the jelly comes forward. It's uncommon. It happens in less than 1% of the time, and I'd say much less than 1% of the time. And we have ways of dealing with that if that ever happened. But again, that's one of the bigger risks. There's some smaller risks that happen somewhat frequently, but we deal with, and that's floppy iris syndrome. You may hear us ask about your use of Flomax or tamsulosin because that is associated with the iris being a little floppy. And then zonulopathy, or where the fibers that hold the lens in place are a little weak, whether it's from trauma or whatnot. Again, these are all things we know how to deal with as surgeons, and it's really nothing for you to think about or worry about, but it's just to indicate that this still is surgery and there are things that we need to keep an eye on. Okay, so we decided you wanted to do surgery. We started talking about some of your preferences, and now we need to get ready for how do we get ready? So the preoperative regimen for me is to always treat dry eye. Even if you don't have significant dry eye, most people have some level of dry eye. And treating this beforehand makes the measurements for cataract surgery as accurate as possible. So when I see you, we'll talk about cataract surgery, we'll decide to do it, we'll talk about the options, and I'll say, okay, now I need you to go home, I need you to start doing warm compresses, basically heating pad, eyelid scrubs to remove any debris from the eyelid, and artificial tears. I have everybody do that before they come back for their measurements for the cataract surgery that determine what power lens is going to go in the eye. That way we get the most accurate measurements. It's like the old woodworking, measure twice, cut once. Okay, it's the same type of thing. So we want accurate measurements so we get good data. Some patients require more than this. If someone has extensive dry eye, someone asked a question earlier about Sjogren's, we treat that ahead of time with different dry eye medications and treatments if needed. Education, understanding. I like to spend a lot of time. I want my patients to be educated. I do these webinars. I give people links to these webinars so they can learn all this stuff ahead of time so there's no surprises or questions afterwards. All right, so now let's talk about the day of. Go back to the preoperative. We will get the measurements. They're quick. They only take a few minutes when they do the measurements, but that's what I use to determine what power lens is going to go in the eye. Anesthesia. I've got some questions about this as well. It's normal to be nervous and anxious. These are your eyes. Your vision's important. We understand that, and that's why we do what we do and why we decided to do what we do, because we know how important the eyes are. Just know that this is, like I said, this is what we do. We do it all day, every day. And so we will help you every way we can and make sure things go as smooth as possible. They do a great job at the surgery center, helping you get situated and relaxed. You have an anesthesiologist and a nurse anesthetist involved in your care. And these are some of the options you have available. Number one, you can go with nothing. I probably do 5 to 10% of patients with absolutely nothing except, drops to numb the eye. So patients who have, concerned about medications or anesthesia reactions, we can do that. You are fully awake and aware, but there's no problem with doing that if we need to, as long as you're, okay with that. Number two is Valium, which is an anti-anxiety medication. When we do laser-assisted cataract surgery, you get some Valium before you go back for the laser. It's also what I use when I do LASIK or PRK, just to take the edge off. And so that's always an option. Local topical, again, is just where they monitor you, but they give you some Versed, for instance, is a common medication they use. And that's how I do the majority of my cases. I'd say 99% patients are awake. They get some relaxation medicine. They do have to look straight ahead. But again, we have this discussion. If someone thinks they would struggle with that, we can do what's called a retrobulbar block. Retrobulbar block is where the anesthesia doctor puts numbing medicine behind the eye and paralyzes it, so you don't have to worry about it moving or looking straight ahead. It kind of takes all that out for you. There's pros and cons. Obviously, it's a little more invasive, which is why I don't do it on everybody. And when we talk about some of the lens options, I actually like you to focus on the light so I know you're fixating in the right place for centration, etc. General anesthesia is rare. I do it maybe once a year for a patient that either has a mental handicapped or severe Alzheimer's or just can't lay still. But again, not common, but an option if needed. All right, so let's talk about medications. This one is going to vary substantially by the doctor you go to. We all do this a little bit different. So on average, you need an antibiotic and a steroid to treat after the surgery. Some people use an anti-inflammatory drop as well. And so some doctors will prescribe 3 different bottles of these different drops to your pharmacy. I use a compounded drop for most of my patients. This is where all 3 of those bottles are combined into one bottle. So you only have to put 1 drop in at a time. And if you come to me, you'll see we send this to a compounded pharmacy. They mail it to you. We get into logistics there, but that's an option. Sometimes we use antibiotics at the time of surgery. Sometimes we put steroids in the eye. One I just wanted to bring up is Dextenza. It's one that I use for a lot of patients. It's where you put a little steroid implant in the tear drainage system where the tears drain out, and that prevents that way you don't need to use the drops for as long. So instead of using the drops for a month, usually we do a taper 4 times a day for a week, then 3, then 2, then 1. So it's over a course of a month, you taper off. You stop the drops after a few days to a week, and then this steroid gives off the rest of the steroid for the rest of the month. Okay. So that's Dextenza. All right, so now we're going to get into the cataract surgery itself. Now let's take a step back. So when I do cataract surgery, I tell patients it takes about 15 minutes. It can take anywhere from 10 to 20 minutes, but on average, it's about 15 minutes once you actually get the surgery started. Okay. I'd like to talk about standard manual incision cataract surgery and laser assisted cataract surgery, which we offer both here. Standard manual incision cataract surgery is where everything's done by hand. That is what's covered by insurance. Okay, so we use 2 small incisions and we break up the lens, put the lens in, all done manually. There's also laser assisted cataract surgery, which is where the laser does all of the cut steps of the surgery. So it makes the incisions. It makes a circle on top of that candy shell to open up the lens. It divides the lens into quadrants to make it a little easier to remove the lens, and then it can correct astigmatism. Okay, so the main reason I use the laser is to correct astigmatism in people with mild astigmatism. So you do something called limbal relaxing incisions for patients that need astigmatism treatment but don't have enough astigmatism for a toric lens, which corrects higher levels of astigmatism. But there are benefits beyond that. We do like the centration feature. It centers the capsule rhexis, helps with effective lens position, etc. So that's that. I offer both ways. I do a lot of the cataract surgery both ways. And the way I tell to patients, it's really an individual decision in terms of what you want to do and how you want to do it. And so that's the laser assisted cataract surgery. This screen shows what I'm looking at whenever we're doing the laser assisted cataract surgery. We kind of connect to the eye, we dock on the eye, and then as you can see on the screen, you can lay out where you're going to put the incisions, how you're going to divide the lens, how that circle is going to go in. You can see a cross section of what the lens looks like, so you can see how thick and deep it is. You can see how deep the chamber is, so you know how much room you're going to work with. And so we go through some of these steps during the surgery. So again, I like the laser. I think it's fun to use, and it does add an extra level of planning precision that I think is nice. But again, it's not covered by insurance, and that's where it's really a personal decision for each patient. Okay. Now we're going to get into the different lens options, and there's a lot of lens options. And if this sounds a little confusing or it's a little in depth, that's okay. That's the reason I'm doing this, is so that for those that want a lot of information, they can reference this and listen to it and learn. For those that don't want to know that much about this, when we see you in the office, we'll simplify it. We'll tell you kind of what the options are and what the recommendation would be for you. But I want a little more in-depth discussion here so that everybody can hear some extra details. Okay. So monofocal lens. Monofocal means it focuses all the light in one spot. Okay, so this will correct nearsightedness or farsightedness, and it corrects for one distance. So it corrects you for distance or near vision. It does not correct astigmatism. It does not correct presbyopia, which is the need for reading glasses. And this is a lens that's covered by insurances. Okay. And so if someone has no astigmatism and they're fine with reading glasses, then this lens will get them good distance vision, and they'll just use readers for up close and probably for the computer as well. Okay. If somebody has astigmatism, then they'll still need glasses afterwards to get their best vision for distance and near, but they'll still have great quality. It's just that they'll need glasses afterwards. Okay, so that's the monofocal lens. Next, we're going to go to monofocal toric lens. So for those patients that have astigmatism, again, small amounts like 0.75 to 1 diopter, that's where sometimes I'll use the laser to treat. When you get above a diopter of astigmatism, then you start looking at a toric lens, which corrects near farsightedness as well as astigmatism. So it's still focusing on one point, distance or near vision. So same thing, if we correct the astigmatism with the toric lens, we'll get you good distance vision is what most people choose. And then you'll still need reading glasses for, reading and or the computer. And that's that. Okay. Now, we'll get into monovision a little bit later. You can always consider monovision with these lenses as well if you've tried it in the past. And so we'll go through that. I do see that patients are asking questions as well. A lot of them aren't related to what we're talking about now. So I promise I'll come back and I'll scroll through and I'll go through all the questions as we go so we can get through everything first. Okay. Next, we're going to move into another lens called an extended depth of focus lens. Okay, so this is called the Vivity lens. The Vivity provides, the goal of this lens is to give you distance and computer vision and functional near vision. So if you kind of hold things out, you can still see them. But if you're going to sit and read a book, you definitely still need reading glasses. Okay. And the nice feature of this lens, it really has a similar side effect profile to the standard lens. And I'll go through that a little bit more here. So the next few slides for each of the lenses I go through are some marketing material from the manufacturers themselves. And so this is a Vivity. It's designed to give you good distance vision, good intermediate vision, and functional near vision. So again, to minimize how often you wear reading glasses, but again, it doesn't eliminate them. So if you are planning on sitting and reading a book or whatnot, you'll still need readers. But it does give you a wider range of vision compared to the standard lens. Okay. This slide, I'll just simplify it. It basically, glare, halo, starburst, some people just have them. And after cataract surgery, it's possible you could have those even with the standard gold standard lens. This slide is basically showing the studies they've done that showed there were no really extra side effects with the Vivity compared to the standard lens. Okay. Now, how does this lens work? And this is where I like to go through a couple things. It stretches the light. And so there's a little bump in the middle that you can see on that lens, and it stretches the light to expand how wide that focal point is. Now, they emphasize that this lens never splits light, and that's why there's not an increased risk of halos or starburst compared to the standard lens, because it doesn't split light. Now, I will say anytime you're doing anything to light, whether it be stretching it or splitting it, you have a theoretical risk of decreased contrast sensitivity, which means, quality or, the precision of the quality, like, black on white, maybe it's not quite as crisp as it would be. So that's a theoretical, it's rare for patients to complain of that, but I tell anyone considering these lenses, it is a possibility that contrast sensitivity is impacted on even the EDOF lenses or the Vivity lens. This kind of goes into stretching versus splitting. So this is the light source. If you look at the first black square up there, all the light's focused on that one spot. Okay. If you go down to the Vivity, the bottom one, you can see that the amount of distance that the light spreads over is much wider, and that's what gets you that computer vision as well. And then if you look at the Panoptix one ahead, which we'll be talking about next, you can see that there's a gap in the light, but that it covers even the near areas at 16 inches. And so that's how you're able to it splits the light into kind of distance and near. But you can see that the highest intensity light is with the monofocal lens. So you do get the most light through to one focal point with the standard monofocal lens. You just need, the glasses for up close. So we'll talk about that. Okay, Panoptix is a trifocal lens. This lens is designed to give you distance, computer, and reading vision all in one eye. The negative on this one, it does have some risk of starburst. Okay. So here again are some information from the manufacturer. Talking about presbyopia, or basically how much time in modern day life we spend with near vision. Reading and writing, mobile crafts, looking at the dashboard or your cell phone or whatnot. So there's a lot of up close work, and this lens was designed to try to reduce how often you have to put something on to see that. The main reason I included this slide was just to show what the lens itself looks like. So the lens has rings on it, and those rings split the light into distance, computer, and reading, which is why you're able to see those ranges. It also, because of those rings, has the risk of some starburst or halos that can cause some issues, say, at nighttime. Okay. Now, that being said, 99% in their initial study showed that they loved the lens, they would choose it again. So what I like to, but you have to be aware of the side effects. And so when I talk about this with patients, I say, listen, if your goal is to be out of glasses, but you're not okay with the risk of starburst, and maybe not the right choice, because even though I usually say, if you look at some of these, this is one of the studies that looks at how many people had these effects. I quote around 30%. I say about 30% have some of these symptoms, but less than 5% are really bothered. And that's what this shows. 5% are bothered by the starburst. Some see it but aren't bothered by it. So it is important to know that a decent percentage of people do have this. Now, overall, my patients typically do not complain about this. Some will say they notice it but aren't bothered, but it is a possibility, and that's why it's important to be educated on these topics. All right, so good. So we'll go to the next one. The next two I'm going to hit on are newer technologies that we're just kind of getting into now here at the Virginia Eye Institute. The first one is the light adjustable lens. This is a monofocal lens. So again, giving you one focal point, but it's adjustable after cataract surgery. So you can fine tune it after the cataract surgery. It does require a longer period until completion. It requires extra visits. It requires UV glasses, and we'll go through that in the next 3 slides. So the benefit, okay, so when we do cataract surgery, we use our measurements that we get before the surgery to choose a lens. We assume that the lens is going to stay where it's supposed to, that you're going to heal the way you're supposed to. The measurements, are accurate, and that that's why we pre-treat you to get them as accurate as possible. But how your body heals and those measurements impact the final lens position, which determines whether you need glasses afterwards or not. So it doesn't impact the success of the surgery from a get the cloudy lens out, clear lens in, but in terms of your glasses prescription, there are some potential error risks there. There are different ways to minimize these risks, and one of those is this lens, where the preoperative measurements really don't matter anymore because you do the adjustments on the end side. Okay, so the way this works is UV light is used to adjust the lens power after the surgery, and so basically changes the macromers or polymers in the lens to change the shape and adjust it after the surgery. Okay, so expectations. All of these choices are about expectations. With this lens, you will need to wear UV protective glasses for 5 to 6 weeks after the surgery. So that means usually you get a basically sunglass pair as well as a clear pair. If you're being exposed to UV light, you're supposed to wear the glasses. Now, they do have a protective film on top of the lens itself to prevent, stray UV light from causing changes. But to be safe, you really do need to wear the UV glasses until the process is complete. After the surgery, there are 2 to 4 additional office visits where you get a glasses prescription, and then the lens is adjusted. And then you go back, you wear the UV glasses for a few more days, you come back, we do another glasses prescription, see if it's changed, see if you're happy with your vision, adjust it again, okay? And when you're doing these adjustments, you can play with it a little bit. You can say, well, this is going to be my dominant distance eye. I'll add some near vision to this eye, and you can kind of test that out for a few days before that. And then you come back for another visit or two to lock in the prescription, so that way it's finalized. Once you lock in that prescription, you then no longer need to wear the UV glasses and things are done, okay? So the benefit of the light adjustable lens is you can make adjustments afterwards if you healed a little bit different. This is a good option for patients that have had refractive surgery in the past, like LASIK, PRK, even RK, because those, and we're going to talk about those in a minute, the measurements are a little less accurate when you've had prior surgery to the eye before. And so a nice option. The big negative is it's a lot of work, a lot of extra visits for you. But it is something we offer, which we're excited about as a good opportunity for patients that want to go down that road. This is another lens that's new to the market. We aren't using it at this point, but we will start using this. It's called the ICE. It's a small aperture lens where basically it's got a filter that lets you look through a pinhole. And so if you've ever been at the eye doctor and they check your vision and then they have you look through a little pinhole and you see better when you look through the pinhole, it's the same science. Is it's only letting the light rays come in straight on, and it can help with kind of an extended depth of focus. So it gives you a little wider range of vision. The side effect profile has been great. It doesn't affect that contrast sensitivity that we talked about. It can correct some mild astigmatism up to a diopter and a half. And you can kind of do a monovision with it. So we'll come back and talk about how that fits into everything as well. So now I want to take a couple minutes here to talk about, kind of outliers or things that come up that people have questions on. So LASIK and PRK, RK, refractive surgery. So if you've had that in the past, it does impact the measurements for surgery. It does impact which lens options are good fits for you. Okay. Again, every doctor is going to handle it a little bit different. For instance, the PanOptix, the trifocal lens. I haven't to this day put it in patients that have had LASIK or PRK because I think they're at higher risk of those risks, the starbursts and halos. That being said, a study just came out that said patients tend to do pretty well with it, even if they've had LASIK. So there's a lot that is still ongoing with research in these special situations and settings. But light adjustable would be a good option. That IC8 lens would be a good option, or just a standard lens. And again, we're talking about this in terms of reducing your need for glasses. The cataract surgery itself for LASIK or PRK is done the same way. So I do it the same way. There's no issues that are going to affect that. It's really just choosing the lens. Okay. Glaucoma is another common question. So glaucoma is very common. A lot of patients are on glaucoma drops. Some people have more advanced glaucoma. Some of the lenses that split light and whatnot are not a good option if you've got advanced glaucoma. There are surgeries we can do at the time of cataract surgery to lower the eye pressure as well, to try to prevent the need for further drops or to reduce the drops that you're on. This is called minimally invasive glaucoma surgery. There are a lot of different options in this realm and different ways of doing it. And, your doctor will talk about whether that's an option for you specifically, and depending on your level of glaucoma, what options there are. Monovision is another fairly common question. Monovision is a good option for patients that have done it in the past or that are willing to trial it. So monovision is one eye for distance, one eye for reading. Monovision in cataract surgery is a little different than monovision in regular life with contacts because the lens is different. So I like monovision with the Vivity lens because it kind of gives you a wider range of vision that overlaps to cover the full spectrum. But a lot of patients that end up doing the Vivity like what they get with the first eye and end up choosing just doing distance and intermediate for the second eye as well. If you've never tried monovision and you're interested, then we'd get you set up with one of our optometrists to get fit for contacts to trial it, because you really need to trial monovision before you do it, in my opinion. Like I said, I also do LASIK and PRK. Occasionally someone tried monovision, didn't like it, and then they come to me and need it touched up or fixed afterwards. So just to be clear, going back to the LASIK, if your refraction or your vision is off from a glasses prescription standpoint after cataract surgery, you can consider something like LASIK or PRK to eliminate the refractive error if some of that exists afterwards. So that is an option as long as you don't have any contraindications. Mixing and matching lens options is actually a very fascinating topic. I could talk a whole hour just about that, where you can kind of mix and match some of these options if you want some of the benefits but are afraid of some of the potential side effects. So I have some patients that have done a monofocal standard lens in one eye, so they get really good distance vision that one eye, and then we put a trifocal like the PanOptix in the other eye, and then it's almost like super monovision. So they've got both eyes for distance, and then the one eye can read up close. And so you can mix and match all these different lenses as long as you understand what you're getting, and it does require discussion with your surgeon about what the options are. Okay. Glaucoma we talked about. Dry eye is very prevalent. We work on that ahead of time. Sometimes dry eye can be a little bit worse afterwards, and so oftentimes we will treat you after if there's any issues. Retina pathology. So this part is just basically saying, if you have any of these underlying conditions, they can affect the options, they can affect your visual potential. If you've had a retinal detachment, or you have an epiretinal membrane, or there's damage to the back of the eye, cataract surgery does not fix that. Cataract surgery gets a cloudy lens out and a clear one in, and can help with the glasses too, but it doesn't fix those underlying problems. Dilation requirements. Some of these options require certain dilation, or how much your pupil opens up. For instance, the light adjustable lens, you have to dilate to at least 6, preferably 7 millimeters to even be a candidate for it, so that the treatments can be done. The laser, you get more benefit if you dilate greater than 5 millimeters, which most people do, but that can be a limitation. And again, I went over a lot of information here. I don't expect this to be completely comprehensive, or if you have questions, that's okay. This is just to give you an overview of all the options out there. But just know that every surgeon does things different. Some surgeons do all of these different lenses. Some have 1 or 2 that they prefer, and that's mainly what they do. Some people do the laser on almost every patient. Some never do the laser. Some are like me, where I offer everything and we make that decision together. Okay. This goes back. So these are the main lenses that we use on a day-to-day basis. So the monofocal lens, the toric lens, the Vivity lens, and the panoptic lens. And so this is a summary sheet. And we've got handouts like this in the clinic that you can see as well. And if you go to Alcon's website, they'll have this there that you can look at. So it shows what distances you'd likely need glasses afterwards and what potential side effects there are. So this gives you a good idea of the summary of what I just said about how often you're likely to need glasses afterwards. Okay, common postoperative questions, and then I'm going to jump into the questions that you guys have been sending, because I know there have been a lot there. Common scenario: someone is laying on in the operating room for the second eye, and they say, "Boy, I don't remember any of this from the first surgery." And so I like people to know going in, you are going to be a little more aware during the second surgery. It's like watching a movie for the second time. We do it the same. We give you the same anesthesia, but you're just a little more aware. So I like patients to be aware of that going in. Spacing of surgery, you can go as short as a few days if you're doing something like the light adjustable lens. And on average, I do 2 weeks, especially with a lens like the Vivity or Panoptics. I bring you back at a week in case we want to make any adjustments on the second eye. But so we can do a week apart. Sometimes for patients that are really nearsighted, I'll do a week apart. That way they don't have to go 2 weeks with the eyes being so different between the 2 eyes. Okay, so another common question I've gotten is, listen, what am I going to do between the 2 surgeries? So you have the option of bringing your eyeglasses in. They'll take the lens out of the glasses in the eye that we already worked on. You can take it to our Huguenot office and they can put a clear one in. It's a small charge, but if you want, for me, it's not worth it for just a week or 2. And so most of my patients just have it popped out and wear it without anything in it. And most patients, you can't even tell that it's like that. That way they can still use the glasses on the eye we didn't do and leave it open. Now, if someone has a huge prescription, sometimes it can be tough to tolerate the difference between the 2 eyes, but unfortunately, you just have to wait till you get the second eye done. You can cover one eye if needed. Now, another question I've gotten is, what about after the surgery? If I decide to go with a lens where I have a lot of astigmatism, I'll still need glasses afterwards. Well, there's no great option between when the surgery's done and 3 to 4 weeks later is when we check you for glasses. There's nothing we can do in the meantime because you have to let things heal into place to be accurate. So most people's distance vision is pretty good, and so they get around fine, and then just use over-the-counter readers for up close, like a +250 is what most people get. Activity restrictions, no heavy lifting, bending, or straining for a week after the surgery, but you're able to walk around, do your everyday activities, move around, use your eyes. You just don't want to put pressure, any straining on the eye. That's what you're trying to avoid. Okay. So that is my summary. Let me scroll back through. I know there have been quite a few here on the questions. Yeah, there's always, besides cataract surgery, is there anything else coming down up the pike? Lots of options for cataract surgery. There's a study in mice showing a drop that helps prevent cataract, but really nothing close to clinical trials that is preventing cataract or doing anything for cataract at this point. that I'm aware of. You're always able to wear glasses or contacts afterwards. You wear a shield at bedtime for a week after the surgery. So that was one of the questions about sleeping. With that shield on, it protects the eyes so you don't rub it while you're sleeping. So as long as you do that, sleeping's fine. You keep your eyes, showering is a great question. So when you shower, you keep your eyes closed, or the eye we worked on, and then gentle pat dry around it for the first few days. After a week, you're fine. It's not gonna hurt. And the next question, how long do I need to wait after cataract surgery to drive my car? This is personal preference and really based on your outcome and where you're at. So a lot of patients come in are seeing really good on the first day, on day one. If you're 20, 40 or better, you're legal to drive. Also, if you still have your other eye with glasses on, you'd be fine. So if you're comfortable, you can drive as soon as the next day. You can't drive the day of because of the anesthesia. The next day, if the vision's good enough, you can drive as long as you're comfortable, but you have to make sure you're comfortable. All right. Dry eye, we talked about that a lot. We need to optimize that before we do it. We talked about the multifocal lenses. Insurance coverage, a couple things came up with that. Cataract surgery itself is covered by insurance as long as you have a functional complaint. So like we talked about, if someone comes in and says, listen, I don't want glasses anymore, but I don't have any complaints, then you're talking about refractive lens exchange, which is cataract surgery when you don't have a cataract. And that's refractive surgery. That would not be covered. But for most of the patients that come in, if you have a cataract and you have symptoms, it is covered. All right. So I don't need glasses to read, but need them for distance. So yes, you can choose distance or near vision. So if we can correct you for near vision, and then you'll just need glasses in the distance like you did before. Most people, I'd say 99+% of patients choose distance vision because it's easier and cheaper to buy reading glasses over the counter than to have prescription distance glasses. But I definitely have some patients that choose near vision as their target. Okay. All right. Is there advantage to doing cataract surgery sooner for keratoconus? I think that's what you're talking about, is keratoconus. So keratoconus is a corneal condition, and that's a complex question that would really require an evaluation. So if you've got stable keratoconus that's not changing and you have visually significant cataract, it's fine to go ahead and do cataract surgery. Again, we wouldn't do cataract surgery if it's not visually significant. And if you are not stable, then you probably should wait till it stabilizes, either with treatment with cross-linking or until it's stable, because otherwise your prescription will continue to change. Question here, I have only one good eye, is there a risk? That's a great question. So patients that are monocular with one healthy eye, there's different perspectives on when to do surgery. For me, the perspective does not change. If you have no complaints, we don't do surgery. If you're having symptoms, then we talk about surgery. So, it's the same thing. You got to protect and optimize that vision. The benefit of doing it early is maybe it's a little easier to get out before it gets too bad. The benefit of waiting is you delay any risks that come associated with that. So again, I had that discussion one-on-one with each patient. You wait till it bothers you enough, and then you do the surgery. Okay. Another question here, I only had one cataract surgery, the other one made it in the future. Is it okay to leave a space in between when they're done, maybe 5 years apart? Perfectly fine. Again, you do cataract surgery when it's visually significant. If the one eye is seeing 20/20, there's no issue, no reason to do surgery. You wait until it bothers you, and then you do surgery. That being said, if both eyes are similar and one's not quite as bad, but it's close, then oftentimes we'll go ahead and get both done. All right, so again, standard cataract surgery is manual incision cataract surgery with the monofocal lens, and that's what's covered by insurance. Okay. How far in advance of measuring drops do you start drops and compresses? Warm compresses, eyelid scrubs, and artificial tears are great for the eyes. They help them feel better. They help with discomfort. So never too early to start those, okay? As long as you're doing them at least a few days, ideally a week or two, but really as long as you get it started. I can tell when I look at your measurements if they look okay or if the surface looks dry. It's not common, but it's also not uncommon for me to look at your measurements and say, hey, let's bring you back in a few days and do it one more time because I didn't quite love what I saw. So it is possible to do that. Will the surgery correct astigmatism? What are the implications of having a thin cornea? And should you worry if there's a history of skin keloids? So 3 questions there. So standard surgery does not correct astigmatism. You either need the laser or the toric lens to correct astigmatism. Otherwise, you treat it with glasses. Thin corneas, unless there's pathology like keratoconus or scars or whatnot, that doesn't impact it for cataract surgery. And keloid scarring of the skin has not been associated with issues with cataract surgery because we're not working on the skin, and the collagen healing on the cornea is different. Okay. Is laser assisted surgery more accurate than manual surgery? That's a very difficult question. So there's good outcomes with both manual incision cataract surgery as well as laser assisted cataract surgery. There's a couple things that the laser offers that the manual doesn't. One of those is correcting low levels of astigmatism with laser limbo relaxing incisions. So you can correct astigmatism. And then the standardization of what's called the capsule rhexis, which is creating the circle on top of the lens to open up the lens, that affects what's called effective lens position, or where the lens heals into place. In my opinion, there is a benefit to having that, completely 5 millimeters, perfectly circular every single time. So yes, I think there's a benefit, but again, we do get good results both ways. Different antibiotics, you're absolutely right. If you have an allergy, there are other options we can use, polytrim, etc. Now that being said, people that had a little GI upset with an antibiotic is not a true allergy, so you can still use them. But if you have a true allergy to anything, we can always use an alternative. All right, I use magnifiers to read, my distance glasses correct astigmatism, and prisms to fix strabismus. Okay, prisms a great question. Cataract surgery absolutely does not correct the need for prisms. So if you have double vision, then you don't want to consider anything like the Panoptics or even the Vivity or any of the lenses that spread the light, and you will still need prism after the surgery. The way to correct that is with muscle surgery, which, if you wanted that fixed, that would be what you do there. Again, commercial insurance does not cover anything other than the standard manual incision surgery with the standard monofocal lens. Keratoconus, another question on that. It's its own condition, and there are a lot of things. We use different formulas to choose the lens. You really need a personal consultation for that to decide when it's right and what we choose. But again, typically we end up doing the standard monofocal lens for keratoconus. There's sometimes a toric. In terms of costs, we have a video that they'll share with you. They can change, just like supply chain and everything else. The cost that the lens costs in the click fee to use the different lasers and whatnot, that can change over time. So they'll actually give you a handout when you come in for an evaluation with what each different option costs, and so they'll be able to go through that with you. Surgery in the retina, laser assisted versus manual incision for the retina, unrelated. So cataract surgery, we're not going to be impacting the retina or previous hemorrhages. Those are separate issues. So the retina is separate from the cataract. So I've known some patients that have some persistent visual system. So I'm not sure what you're describing here. You're asking about a visual phenomenon afterwards. There is something called dysphotopsias that you can have after surgery, where in the short term, sometimes you can see the edge of the lens for a short period of time. It's uncommon, truthfully. Some patients will have it that persists, but again, very uncommon. There are things we can do for that, either glasses, secondary lens, etc. Those are a little more invasive, so we don't typically jump to that because typically people adjust to this. With any of these lenses, whether it be the monofocal lens or one of the other lenses, there is a neuroadaptation period where it takes the brain some time to adjust to and get used to the lens we have in your eye. Does it matter how bad your astigmatism is? Yes. So if you have minimal astigmatism, we don't need to correct it. Mild to moderate or severe, then we talk about the options. And again, glasses, contacts are always an option afterwards, as well as the lens to correct it during surgery. I'll do my best to get to everyone. It says I still have 18 messages, so I don't know if we'll get through everything, but I'm doing my best here. How is quality control of the various lenses reviewed? Great questions. That's really done by the manufacturer. We do look at the lenses before they're inserted, make sure they look good. But most of that's done from the manufacturer, and that's why we use all well-known, well-vetted manufacturers for these lenses. Will this correct floaters? No. We're only working on the lens of the eye. We're not working on the jelly behind the eye, which is where floaters are. Doesn't impact whether I can do the surgery, but it will not take the floaters away. Fuchs dystrophy, that's a great question. That's where the pumps in the cornea don't work quite as well, and it can lead to a delayed recovery after cataract surgery. It depends on how advanced. I do a lot of patients that have Fuchs dystrophy. Most heal just fine in the same amount of time as anybody else, but I always warn people that it can take longer to heal. Let's see, what else here? Will the new lens wear out over time? No, this is one-time surgery. We do not take these lenses out unless there's, an issue. But again, we almost never take these out. And someone asked about stability before. So most of the glasses prescription changes you've had over the years are from the lens changing, and that goes away. The cornea can still change a little bit over time. Typically it's mild, but just know that it can theoretically change some over time. The questions specific to what you need, I'd recommend an evaluation so we can talk about it in detail. But if you want to keep your near vision, then we just aim for near vision, and then you use glasses. So that's just standard surgery. That's fine. Pattern dystrophy, again, retinal issue, won't really impact cataract surgery. If it's not visually significant from the retina standpoint, then it doesn't have an impact. I've had glare since my 20s. Did this indicate cataracts back then or other glare? Some people have glare. There's other reasons for glare than just cataract. So in someone that's had it since their 20s, it's unlikely it's directly due to the cataract. If the glare has gotten worse, then that may be contributing, but no, it probably wouldn't fix all the symptoms in a case like that. A couple questions about seeing me. I'm happy to see new patients. I've got, we have openings in the schedule if someone needs an evaluation. You can call the call center and ask to be put on my schedule. I have a number of the docs that do send patients to me for some of the specialty lenses, so you can always ask them as well, but you can just call and make an appointment. We'll evaluate you and take a look and see how you're doing. Why do I have to wait until it's really bad? You don't have to wait till it's really bad, but you do have to have a functional complaint in order to qualify for cataract surgery. If I know I will need a vitrectomy surgery, which will cause cataract, can I have the cataract surgery first? No. So we do the retina surgery first, the vitrectomy. Sometimes it takes a year or two before the cataract develops, and then we'd take care of the cataract at that point. Can you drive afterwards? We addressed that. As long as you're comfortable, you can drive. Costs, again, they'll go through all that because those can change. So I don't want to misspeak if something changes. So we'll give you the handout when you come in. During surgery, your hands tied down? No, absolutely not. You are on a comfortable bed. You have a drape that only goes to about your shoulders. It's a clear, kind of a translucent drape. I'll be talking to you. I'll have some music playing in the background. I'll tell you just where to look if you have any issues. Sometimes I'll talk to patients during if they have questions, but no, it's a pretty relaxed experience for you. So we talked about that. Macular degeneration definitely impacts what lens you choose and your visual potential. And again, some of these questions are easier if we do, the consultation where I can go through your specific details and look at your imaging and whatnot. So that's that. All right. So it looks like I hit just about everything. Panoptics glare question. Most of the people that have had any issues, it's with headlights at night. Theoretically, it could impact you during the day, but I haven't had any patients with an issue like that. And a posterior capsulotomy after, so you have that resolved. Good. So yeah, we can do manual or laser assisted if it's a thick cataract. Both are options. So I think they keep coming. We'll do 2 or 3 more questions, and then I got to get back to clinic because I think there's a couple of patients getting ready for me. It looks like I got. So if there are more questions, because it looks like they're still coming in, you can always send some questions to Melissa, or we'll do another one of these sooner than later so that more questions can be answered. Like I said, the best way to answer the questions, especially the ones that are specific to you, your eye, or specific condition, would be just to come on in, see us. We'll do an evaluation. We'll do a comprehensive eye exam and see what's best for you. Okay, I hope that was helpful for everybody, and I'm really excited how many people were able to come in and see this, and happy to see in the future.
Yes, thank you so much, Dr. Tucker. And as I mentioned earlier, this will be recorded and sent out to everybody who attended in an email. And I can save all of your chat questions and share them with Dr. Tucker as well, but you're welcome to email the original email on the invite, and I will make sure those get to Dr. Tucker as well. All right, well, thank you, everybody. Thank you so much for your time, and hope everybody has a great rest of your day. Bye. Bye, Dr. Tucker.